listen-only mode for now. So we're going to go ahead and get started, have some introductions of our guests that are here and on the phone, and then we'll have roll call. Okay. So Terry West and Will
Yakabuchi
are here in person from IHS Market It, and Tim Dahl is on the phone. So Georgia, I'm going to turn it over to you for a roll call.
You're going to turn it over to Joelle.
Okay, so this is Joelle Judge, and I have a few folks in the room, all of whom I recognize. So we have David Adams here, and I can actually see who has signed in to the webinar. Molly, back up, are you participating at all by phone? And I just don't see you here. Okay. And so we have Rick Barnett here. I see Peggy Brosizovic on the webinar, and Lindsay Herbert I see on the webinar. Monica White is here. Charlie McLean is on the webinar. Maribel Colombo is here. And given that I can see Denise Clark is here, that's helpful. We don't quite have a quorum. I need 12 for a quorum today, so we're just a few folks shy in terms of approving your minutes.
Okay, so let's reorder the agenda for the minutes after a little while, and go ahead.
I can keep track, Mary Val, and if folks sign in, I'll catch them.
Okay, so now Georgia, I'm going to turn it over to you for.
Thank you. So just a couple of updates. First, we're going to talk a little bit about our sustainability plan. And I think as we talked with you all previously, your sustainability path is slightly different from everyone else in SIM, so you're special. But your group was created by executive order, so that means that as we go into 2017, your group would still continue to meet and continue with your charge and review of the workforce strategic plan and implementation of the components of that plan, unless and until the governor-elect makes a different decision. So thank you for continuing on in your role, and stay tuned if anything changes as we go down the road. Secondly, from a co-chair update, I think you all may have seen Robin Lunge was appointed to the Green Mountain Care Board, so she is no longer able to serve in a co-chair role as a representative of the Secretary of Administration. I think you also may have seen that the governor-elect appointed a new Secretary of Administration just yesterday, so we're very excited that she's coming on board. And so, I would anticipate that she will make her decisions about the administration's representative on this group, in due course over the next few weeks. I don't think there are any other updates that I had. I'm looking to Amy to see if there were any others that I am forgetting.
No, just that we're in a holding pattern until the new Secretary of Administration completes reviewing the transition plan from the former Secretary of Administration, and then they will put forth a recommendation for a new co-chair for this group.
Thank you.
Great. So without further ado, we're going to turn the agenda over to our guests for our long-awaited discussion of demand modeling for our state.
Yeah, so I think I'm going to kick this off and then turn it to our guests. So, for folks, we chose a different style for today's meeting, a webinar, for two reasons. One, we want to make it more accessible to folks, and two, we can record it so that we can have it for posterity. I think you all know me, Georgia Maharis, and I'm going to be helping to moderate this meeting. I want to go over a few items just so folks know how to participate in the meeting. So on slide 1, which says before we get started, this is the attendee interface screenshot. On the left side of the slide, you'll see a screenshot of the webinar's attendee interface. You should see something like this on your own computer desktop in the upper right corner. You're listening in by your computer speakers by default. If you would prefer to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. We've set aside time for discussion and questions at the end of this webinar. You'll have the opportunity to participate by typing your questions into the questions pane of the control panel at any time during the presentation, or by clicking the raise your hand icon so staff can unmute you and you can ask your question aloud. If you plan to ask questions aloud, please make sure your computer microphone is working or use the telephone audio option. As I said before, today's event is being recorded, and the slides and the recording will be posted to our VHCIP website in the next few days. So our presenters today are Tim Dahl, Terry West, and Will Yacobucci from IHS Markit. So welcome, gentlemen, and we will turn it over to you. Thank you.
Well, thank you very much for the introduction. We're happy to be here today. We're thankful that you invited us. We've been working on this study since May, and what we want to do today is present some draft study highlights, findings, and results, and have a discussion about the potential implications of these draft findings, and talk a little bit more about what our next steps are going to be to bring this to full fruition. So if you could go to the next slide, please. Thank you. The agenda today, Will and I are going to ping pong back and forth across various aspects of the agenda. We'll start with just a very brief overview of the workforce study goals and objectives. Then rather than waiting till the end of the presentation to tell you what the key findings and implications are, we're going to share those with you right up front. And then Will is going to give everyone an overview of our microsimulation demand model, its methods, its data inputs, the assumptions under which it operates. Then we'll talk about a very important topic pertinent to service and workforce demand, which is population projections and service demand projections, and how those then lead to our projections of the Vermont health workforce by physician specialty and by select health professions. After that, we'll show you some modeling results that we have for a number of scenarios that we've run that we think would be part of a high-performing Vermont healthcare system. And we're going to revisit these scenarios to build out a few others that people have indicated an interest in, to the extent that that's possible. And then we'll talk about project next steps. So it's a fairly meaty agenda. If I appear to be going too fast, just slow me down. We'll go to the next slide. Thanks. Also, we've been working on this project for about 7 months now. And the overall goal is really to model and analyze demand across health workforce professions and physician specialties to inform state and local policy and planning. That's the 30,000-foot explanation for the primary study goal. And to do that, we quantified both current and future demand for health professions through 2030. We looked out 15 years, and we did so both at the statewide level and by HSA and care delivery settings under a number of different scenarios. In most cases, when we develop a scenario and share those with you, we compare the results of that scenario and its findings with a status quo, which essentially means if we maintain current healthcare delivery patterns and if we take into account more or less just population demographic characteristics and changes in those and current prevalence of disease and risk factors. Comparing the two, what do we see are the differences and what are the implications of those differences? So that's just an overview of the study goals and objectives. Go to the next slide. Thank you. Let's start with a summary of what we have seen over the past 7 months in terms of key findings and our take on their implications. And I would say it's a complex and shifting environment. So there's plenty of room for alternative interpretations of some of these findings and their implications. Next slide, please. Thank you. When all is said and done, population aging is the primary driver of Vermont healthcare service and workforce demand growth. If we look out 15 years, what we see essentially is that overall the state population is projected to decline by about 1% overall. But that hides a number of striking characteristics, particularly what we see as growth in the population 65 and older. We see that population growing 50% by 2030. We also see a small amount of growth, maybe 3 or 4%, in the population just under that, from 34 to 44. But as you look at the graphic here, you see all the other population cohorts are declining. The one that isn't declining, the 50% growth in the high-age population, that is the group that drives demand for care and will drive demand for care into the future. The implications of that, can we go on to the next slide, please? Thank you. And as we look at that, even though we see overall population declines, because of the steep projected growth in the older population, we predict that physician demand will grow here in Vermont, will continue to grow. And we see it overall by about 13%, due largely to population aging, as I said. That 13%, though, if you look across physician specialties, and we group, we'll show you later how, we grouped physicians across 4 specialty categories: primary care, medical specialties, surgical specialties, and other specialties that don't fall into those 3 groups. If you look at each of those groups, we projected primary care will grow, demand for primary care will grow the most on an absolute basis, and demand for medical specialties, mostly internal medical specialties, will grow the most on a percentage basis. Go to the next slide, please. Thank you. We also looked at RNs, and we're projecting a higher growth rate for RNs compared to physicians. We're projecting about a 22% growth in RN demand in the state. And as we looked at that by setting, and you can see we looked at a fair number of care settings. They're on the left-hand column. What we see is that the largest percentage growth, again, in response to the aging population, we see being in home health, nursing home, and residential care settings. We see growth ranging from 41 to 69% in those particular settings. But we also see a continuation of a large absolute growth of nurses in hospital settings. So on a percentage basis, it's the home health, nursing home, residential care settings that will be treating the elderly population. And we see a reduction in school settings as that projected population declines. Next slide, please. Thank you. We looked at a number of other Vermont health professions, about 15 in total. And as you can see, there's quite a bit of variation, but what is compatible here is the high projected growth rate in direct care services, i.e. nurse aides and home health aides. That's consistent with the growth of demand in long-term care settings. So we see the beginning, the emergence here of quite a bit of consistency across the demand for the health professions. A number of other health professions we project to grow faster than population as well, particularly in diagnostic services and certain other professions like dietitians, podiatrists. Next slide, please. Thanks. So then, what we're going to share with you in greater depth later, we modeled components of what we call a high-performing Vermont healthcare system. And we looked at a number of different scenarios modeling future workforce implications of changing care use and delivery patterns. We looked, for example, at what would the implications be for physician demand through greater use of integrated care delivery models. What would some of the implications be? And in a nutshell, what we saw was essentially what you probably, to some extent, would intuitively guess, which is increased demand for primary care physicians and decreased demand for certain other medical specialties. However, there was one slightly surprising finding, is that under these integrated care delivery models, we found increased demand for some surgical specialties in addition to primary care specialties, which is interesting. We also modeled a scenario which focused on expanded access to mental health and substance use services through integrated team-based care. There, what we found was increased demand for a whole host of professions that focus on care coordination, such as clinical social workers and care managers in patient-centered medical home settings. And in turn, we found fairly significant drop in demand for nurses in ED and inpatient settings under this particular scenario. Then we looked at a scenario where we focused on improved care transitions. In this case, it was improved care transitions to reduce avoidable emergency department use and redirect that avoidable use to primary care settings. And again, the results would be, as you might suspect, lower demand for EDRNs and much higher demand for primary care physicians and nurses in primary care settings. So it suggests the opportunity to shift workforce across settings to meet policy goals and to meet changing care delivery patterns. And then finally, we looked at improved evidence-based chronic disease management, where we focused in this particular case on cardiovascular disease, and we went to the literature and looked at a number of models that have been deployed elsewhere. And what we essentially found was that improved chronic disease management increases demand for primary care providers, for health coaches, for care coordinators, but again, reduces demand in institutional settings across a number of different professions. So there's a certain level of consistency across these scenarios. Could you go to the next slide? Thanks. Here's the hard part. So what are the implications of all this, especially today, when things perhaps are even more complicated than when we began this project 7 months ago? So as we say, the implications are unclear, the environment's complex, but some of the factors to take into account are, as we look at these emerging care delivery models, what will the speed of adoption and growth be? And what will the effect of this changing environment be on organization and patterns of care, both here in Vermont and elsewhere? And to what extent will it differ based on Vermont's unique characteristics with other places? So then, examples of other factors that are likely to influence future demand for Vermont health professions, it's extent of care migration from institutional to community and home-based settings. How fast will that take place? Where will that take place? Under what models will that take place? Here's one that's becoming more and more important as the days go by. Changing healthcare payment and coverage policies. What's going to happen to ACA, for example? More effective chronic disease management, team-based care. What are the implications of all these things? And even economic developments. For example, if you look at the literature, you'll see that during the last recession back in 2008 and 2009, that recession influenced supply and demand by slowing retirements. We know that nurses came out of retirement to go back to work in some cases. And consumer demand for many services fell because disposable income fell and people didn't have jobs. So, what could happen under certain assumptions are there. We have heard, though, that the modification of Vermont waivers in the short and the midterm are not likely. So I think we're looking a little further down the road here with respect to the implications of some of these modeling results. And this is sort of our high overview of findings. We'd like to get into a little more detail with you now. Would you go to the next slide? Oh, we're still not done with the implications. It's not just the future implications of modeling results, but that leads to the question of, in terms of health workforce modeling, what are some potential future research directions to take? One is to look at some of the results of this study and say, well, are there specific professions that we want to focus on in greater depth that may experience future shortages? For example, professions focused in areas where the illness burden is increasing, oncology, cardiology, pulmonology. We know the demand is growing there. We need to take a closer look at that. Another possible direction to take in the future is to integrate supply and demand projections and look at adequacy of supply. That would give you a profile of the size and characteristics of Vermont's health workforce together with projected demand. Just some thoughts for future research directions. Next slide. Thanks. I'm going to turn this over to Will for a little while. He's going to walk you through our microsimulation demand, workforce demand modeling methods.
Yeah, thanks. So,
Thanks.
yeah, okay. So we're going to try to keep this brief and as simple as possible, but it's, it can get complicated, so if there are any questions, feel free to let me know. But so here on the screen, we've got a sort of schematic diagram of how our workforce model works, and our broader workforce model kind of includes our supply model, but here we're mainly focused on the demand component. So if we just look at the center of the schematic, the demand model, it's showing that the demand model is starting with our population, and then we've got population demographics, individual level disease, whether or not somebody has particular diseases, whether or not any given person smokes, or different socioeconomic information or insurance information, and we use this information to then use. So we use healthcare use patterns that we predict using kind of a national source of called the Medical Expenditure Panel Survey, which helps us run several different regressions which relate the population characteristics to, say, the probability of a given person having a hospitalization, or going to a cardiologist's office or something like that. So we take the population, we apply the healthcare use patterns, and then those two combined kind of will predict our healthcare demand. And we're doing that by setting and by disease area or physician specialty. And then we go from the healthcare demand projections to provider demand using provider staffing patterns. And this is usually like a visit to provider ratio, where we'll go from the number of, say, cardiology visits to the number of cardiologists needed to support that level of visits. And down at the bottom here, we've got patient and population management and disease prevention and treatment. And you can see the arrows kind of pointing into the population and the healthcare use patterns. So if somebody was to improve their health, or say manage their diabetes, they'll probably have fewer hospitalizations or something like that. So their healthcare use patterns will change. Potentially, in order to implement a disease management initiative, maybe you need more, more staff to just implement the initiative itself. So it could also factor into the provider staffing patterns. Okay, so again, we're going through the modeling methods quickly, but it's I think you guys have the handout of the presentation. So if you're interested in looking at the methods in more detail, it's definitely been described elsewhere. It's the same model that's used to develop many of HRSA's workforce projections. Also, the Association of American Medical Colleges physician workforce projections use this model. And we've also got a very detailed technical document on our website if people are interested in that. So with that, I'll go into a brief discussion of the methods here. So again, we've got several professions modeled: physicians, advanced practice nurses, physician assistants, nurses, We've got several different specialties that we model, and several different professions. Some of these professions we'll model by setting. Some of them we won't due to data limitations. But this is just kind of an overview of most of the professions that we've got in the model. Okay, so basically here is kind of a step-by-step approach of what we're doing. So our microsimulation model is based in SAS. So we've got what we call our population file, which is intended to be kind of a representative population of the state of Vermont, kind of representative at the county level. And this is coming from the American Community Survey, sort of the Vermont subset of that. So we've got kind of each person has their own sort of row in the file. And so for each person, we have individual level information on what diseases they might have, or, you know, their age, sex, race, you know, what type of insurance they have, and so on. And so then we, based on the healthcare use prediction equations I mentioned earlier, which are based on the medical expenditure panel survey, we'll then apply these prediction equations to the individuals in our population file, and then we'll come out with individual level predicted healthcare use. So how many visits is the person expected to have to a cardiologist's office, you know, each year? So the healthcare use prediction equations are based on national data, but we do our best to try to calibrate that to Vermont data. So we've started to do this with the Vermont Uniform Hospital Discharge data set, and we've done that in the I think ED and inpatient settings. We've done that, but we're still waiting on the VHCIP database, and once we receive that, we'll kind of move that farther along. Okay, and so up to this point, we haven't been talking about projections. You know, the healthcare use prediction equations basically predict healthcare use in the first year, and then we use projections of population growth or shrinkage, and also population aging and how the population in general is expected to change over time. And we use that information to predict at the individual level, you know, how a person's healthcare use is expected to change over time. So we use the population change to inform the healthcare use change over time. And so I'm talking about, you know, individuals' healthcare use changing over time. We're not so concerned with that, but we kind of will aggregate it to the HSA level or to the state level. So we'll aggregate each person into this in the state up to the state level. Right, and then we use our staffing ratios to convert predicted service demand into full-time equivalent providers. So I guess at this point I would stop for any questions.
So let me check in with the folks to see if we have any questions. That's one. So the question we had that came from Paul Bankston is that he understands the projections and the implications for Vermont's economy. I mean, the question is, where are we going to find these professionals? It's interesting to know we will need so many more primary physicians when so many are leaving practice, and so if you are choosing primary care as a profession. He concurs that with the presenters that this is hard work, and so I think this is actually perhaps more of a Mary Val question, because I feel like this is part of the work group's entire job, is to help solve problems like this. Not put on the spot, Mary Val, but...
Oh, thank you, Paul, for that question. Yeah, I don't think it's a question about the methods of the demand modeling, and it's, with all due respect, Paul, I'm going to table that question for further discussion a little bit later. I had a question. Are you just taking questions on this slide, or can I go back to you? No.
I think going back to you makes sense, and I would also just note that Rick has a question as well. So, Mary Bell, you go first.
Okay. You had a projection of 22% growth in hospital nursing at one point. And then you said that there was going to be a lower demand for inpatient and ED nursing. I didn't know how that was. I understand the ED, if we do a better job of keeping people out of the hospital, but some of the research that I've done with Betty Ramber in the state has shown an increase in hospitals, in nurses working in hospitals, when we thought, 5 years after the Affordable Care Act, we would start seeing more of a shift into outpatient management away from the hospitals, but that, in fact, has not been the case. So when you saw 22% growth in hospital nursing, I thought, well, that makes sense. But then it seemed to kind of contradict this on that on slide 9.
Yes, slide 9.
Oh, here.
Oh. So which one are we looking at?
Oh, so this might be referring to one of our modeling scenarios. So this isn't necessarily our baseline projection here. This is so which point are you asking about?
Actually, I could make 2 points on that. The projected increase in nursing demand in inpatient settings.
Yes.
What we're seeing is that as the population ages, the conditions for the people being admitted into hospitals are more severe. Their service intensity weights are higher, which requires more nursing resources. I agree with you when you say that, we thought that we would see a larger and more rapid shift from inpatient to community settings, but we're not seeing that rapid a shift.
Mm-hmm.
I think part of the reason is that there was this sudden flurry of activity that has slowed down a bit as people take a step back and ask the question, what results are we seeing from some of these new emerging models? And a lot of the results are either preliminary results or, and this is not good for us, or the results and the evaluations are focused on financial matters and quality of care matters and not workforce. I think that's something that we're grappling with on the workforce side.
Rick, do you want to add anything, Tim?
I was just going to say, yeah. Can you hear me?
Yes.
Okay. I was just going to say that also some of this might be a little bit of an accounting issue in how nurses and patient care is counted. For example, if a person goes to the hospital for surgery and is in the hospital for 23 and a half hours, that might be the same amount of nursing care as if the patient were there for 24 hours. It just might be counted as an observational day or an outpatient visit as opposed to an inpatient day. But I think Terry is right that even though there are efforts to keep people out of the hospital, at some point as the population ages, their healthcare needs just require that they be in the hospital. So even if per capita rates of hospitalization decline, the fact that everyone's getting older means more hospitalizations. And then as Will pointed out, the scenarios that we modeled suggest that with these interventions we can reduce the growth in hospital-based care, but we can't reverse it.
Yeah.
I think, Rick, did you have a question?
Yeah, my question was probably obvious, but worth repeating. On slide number 14, it says where some of this demand modeling is coming from, or has come from, and where it's developed from. And on slide 15, it shows the health professions model. The question is really looking at on the left side of that slide, the other health or the health professions model. I'm just curious what looking down the list and seeing dietary and nutrition professions, and I'm just wondering where if naturopathic physicians and physical therapists, occupational therapists, other health professions. It's always a struggle to sort of which ones to include, which ones not to include.
Right.
But I was just curious why those were chosen and not other ones, or.
These were chosen primarily because there is a fair amount of data and information available to allow us to conduct accurate modeling. When you get an opportunity to read our draft report, you'll see a discussion of the naturopaths. And we did take a look at them here in Vermont and acknowledge that in the future, they're going to be an important resource to help support primary care, provision of primary care. It's just that at the moment, there isn't enough data available for us to use to do the type of modeling that we feel comfortable with. But we pointed to it as a profession to keep an eye on and to track over time.
Monica, so relative to the aging population, we started to speak to that a little bit. There's no doubt that Vermont is a rapidly aging population, but if you can speak a little bit to the modeling factors on slide 7 relative to a 69% increase in nursing home RNs. We, as you may or may not know, had a significant success in Vermont in the last 11, 12 years in terms of reducing our nursing home utilization in favor of home and community-based, and you talked to that a little bit in the subsequent slide, but just the 69% is far off of the 50% kind of growth overall. So I'm just trying to see how those lined up.
That's a good question. So, Will, what were the demand drivers for the nursing home?
It's basically that you've got among your oldest population, in percentage terms, that older population, age 75 and above, is growing fairly rapidly. Now, it might be that that perhaps the nursing home growth might be a little on the high side, and our estimate of residential care might be a little on the low side. So there is some possibility that at the margin, if there's more shifting from nursing homes to residential care or to home health, that some of those numbers could be off a little bit. But even if it were off a little bit, in absolute numbers of people, the numbers wouldn't be that much different. For nurses, the most important one we want to get correct is the inpatient, because that's where the bulk of the nurses are. I mean, clearly all of them are important, but the main driver is that you just have, among your oldest elderly, that population is growing very rapidly.
And so just a quick footnote, I think the IHS Markit team mentioned this, so they've used some of the data we have available. We're still waiting on a major data set being featured. And I think, frankly, we'll look to you, Monica, if there's additional non-claims-based data that Dale has that would be valuable to help shed light on this particular question. I think that would be really incredible to add into the modeling. Because I think there's we're talking about the baseline of where we are, and that there could be some modifications based on data updates. So, and anyone else, of course, not just your department, anyone can contribute data. Go ahead.
I would also note that currently we are doing work with HRSA to strengthen the long-term care component of our model. And so we're incorporating the prevalence of activities of daily living limitations among the population. And there's a good chance that by the time we finish up this project, we will be able to refine the long-term care component of the projections based on the ongoing research we're doing for HRSA right now.
Yeah, I'd definitely love to follow up offline on that. I'm not the data expert in our department, but I would definitely hook you up with our data guru who can help sort this and refine it. I think it's a big component.
And I have a couple of questions. One data point that struck me on slide 8 was 2% growth in dental care, dentists. That was interesting to me, just relative to what I sort of think about. That was, just a comment.
It's fairly consistent with the projected overall population growth.
Yeah.
And the idea of being, regardless of your age, you need dental care.
Yeah, just what I know about the current supply of dental care. That was I think the larger question for me was like in terms of validity of sort of national models of healthcare workforce supply that we needed to use for the model. Likewise for the demand in terms of the, how granular and how Vermont matches up. And the point that you made about does that kind of pass the sniff test with what we see on the ground relative to maybe a national data set that might not be fully fleshed out because of one, a big missing piece of data, and two, a sense that maybe Vermont healthcare delivery is a little bit unique relative to perhaps larger data sets like the the expenditure panels and so on.
Yeah, so actually I think, this is George, I think I'll take that one because that's when we put this out to bid. You have your choice of who does your modeling and what type of microsimulation demand model that you're building off of. And frankly, I think we have some healthy debate as to, do we want a custom Vermont model, which would be very expensive, incomplete, and not necessarily get us that big a bang for our buck, compared to adopting and adapting a national model with Vermont-specific data sources. So I'd say the example of how I think we worked through this well, not to put Matt on the spot, but there were kind of national population trends that were initially baked in, and that's like, we've got very specific modeling in Vermont about how we see this going, and that's being incorporated into the model. So I think, again, to the extent that we didn't want to hold this back from you guys, we had some information, but to the extent that there's additional data that we can put in to make it even better, I think that's great. And that I also would note that it's a microsimulation demand model, which is, it's never going to be perfect, right? We're trying to predict the future to 2030. So again, to the extent that over time there's newer, better data to inform it, I think that's really valuable. And the point of this is to use this as just another input for you all and others who are working on workforce supply side to say, if we're going to need 2% more dentists, and there aren't any coming down the pipe, how do we make that happen? So I think it's this isn't intended to replace all the other great work. It's intended to be an asset to add to all of the work you're doing, just to provide a little bit help from a kind of prospective viewpoint.
Yeah, but I worry about that dentist number too. What if we need 50% more dentists, and we look at this and say, okay, well, we're going to put all our efforts in podiatry.
I'll say that without this information at all, you'd be like shooting blindly. So other than primary care. So I think
well, we have the supply side. And that's why I was kind of curious how much you tapped into that and Peggy's data, because we have mandated supply data from our licensed health professions in the state. And, in that data set, you could look at all the dentists that were 65 years old and know that they were going to age out. Is any of that factored in here?
We took some look at supply data that was made available to us. It was somewhat incomplete. There were holes. There were a number of professions not represented. When we went comparing the demand projections we had with the supply data that was available to us, it appeared that there was currently a small shortage of physicians, for example. But there's a lot of caveats that go into that, because there were certain physician specialties for which the supply data was not available, like radiologists, for example, pathologists, a few others. So it was really an incomplete analysis. I agree with you that it would be ideal to be able to identify adequacy of supply. In other words, be able to compare supply with demand. That would be ideal to the extent the data is available. And, we've worked with others in other states to do just that. And it's a valuable resource to have.
Yeah. Hey, Terry, if I could also add, with respect to dentists, what we're modeling here is the demand for dentists as opposed to need. And for dental and for psychiatric type care, the need is much is likely very much greater than demand. And for dentists, what we have is we have people that have lack of access to dental care, but it's not because there's enough dentists around, it's because of price. The cost is too high.
Yep.
So if you were to throw a bunch of more dentists in Vermont, it might not improve access to care because it's not a supply issue, it's a financial issue or financial barrier.
Right. It's an access barrier.
So this reflects demand or what people are likely to continue using under the current pricing scheme about how much it's going to cost for their care.
Thank you. That helps.
At the risk of stifling questions, I just want to hold them for a little bit to get through a few more slides because I feel like we've started down some amazing questions, frankly, and that's part of why we're here today. But we want to make sure we can get through the baseline deck because we can continue the conversation over the next several months, fortunately.
Right. So let's see.
Okay, right. So once we've got our demand projections, we then translate that into full-time equivalent providers. And so these staffing ratios can come from, various sources, different surveys. Some national organizations publish this type of information. Oftentimes it'll come from like national ratios, say of home health aides to home health visits. And in other cases, it'll come from reported statistics and published literature. Okay, so we'll just close out the methods section with, again, another diagram. So we've got, again, in the top right corner, our population database, and that's the population of Vermont and all of their characteristics, the individual characteristics, age, sex, race, ethnicity, insurance, different diseases, and so on. Combining that with utilization patterns, we then get in the middle of the slide the demand for services, and we do that for physicians at least and nurses in multiple settings, so inpatient days, we're predicting emergency visits, office visits, outpatient visits, and so on. And then at the bottom, we apply the staffing ratio to our predicted number of visits or days, and then we'll get the number of the projected number of people working in the profession.
Thanks. So I'll step in for a few minutes, and the next section of the presentation is take a look at the results, our results regarding projected service demand and population. Tim, did you want to say something? I thought I heard you.
Nope.
Okay, thanks. You're familiar with this particular graph because we shared it with you during our presentation of the key findings. Again, the key finding is that Vermont population on the whole is declining slightly but aging rapidly. Next slide, please. Thank you. And here what we've done is sort of juxtapose trends, projected trends in the population age 65 and above with service demand across a number of different care settings. And you can see the pretty close correlation between the population projection, for example, and home health visits, and a little bit less of one with outpatient visits and emergency visits. Next slide, thanks. So with this as sort of a backdrop, with a look at population and service demand projections as a bit of a backdrop, what we wanted to share with you fairly quickly was some demand projections by health profession. And what we looked at was physician specialties, and we modeled about 35 different physician specialties, and we'll show you in a minute how we did that. We looked at physician assistants. We looked at a number of different advanced practice nurse titles. We looked at registered nurses, and then we looked at a number of other occupations. Essentially, it's similar to what we shared with you in the key findings, only in greater detail, because we looked at them across care settings and HSAs. Next slide. So I mentioned that we modeled a large number of physician specialties. here's the crosswalk of how we group the individual specialties into the 4 physician specialty categories that we shared with you earlier. This is consistent with the way we grouped physicians in our work with the AAMC and several other organizations as well. It gives you a flavor by type of physician specialty. Next slide. Thanks. So overall, we're projecting about a 13% growth in physician full-time equivalent demand overall, but that growth varies from about 22% in medical specialties down to about 10% in primary care. Although in terms of absolute growth, primary care will lead going into the future. Next slide. We also modeled physician full-time equivalent demand by care setting. And as you can see, in absolute growth terms, the majority of growth will be in physician office settings, which shouldn't be too surprising to anybody. And the lowest growth will be in the emergency department setting. Next slide. Thanks. We also went to some trouble to convert Vermont counties into HSA and modeled physician FTE demand by HSA. There shouldn't be any huge surprises in this slide. As you might expect, Burlington is projected to have the largest absolute growth. After all, it's the largest HSA. In terms of percentage terms, though, for whatever reason, St. Albans seems to have a fairly high projected growth of about 18% compared to 13% statewide as a whole. And we did these same projections for all the other health professions. We're just not going to share all of them with you here today, or we'd be here for 4 hours. So next slide, please. Thank you. We also looked at physician assistants, since as we look to the future, we consider them to be an important component of the health workforce. And we were able to break out physician assistant demand by specialty category. So as you can see, we're projecting the largest percentage growth among surgical specialties, but the largest absolute growth among primary care again. Next slide. Thanks. We looked at a number of different advanced practice nurse professions, including nurse practitioners, certified registered nurse anesthetists, and nurse midwives. And across the category, across the APN category, we're projecting about a 12% growth, which is close to the projected growth for physicians as well. But the interesting part, I think, is CRNAs. We're looking at a 17% projected growth, which, if you go back and look at some of the growth in surgical physician specialties, is pretty close. So all in all, we also found that among the nurse practitioners, about half the growth is going to be primary care, and the rest will be spread across medical and surgical specialties. Next slide, please. Thank you. Also looked at projected growth in RN demand by care setting. In this case, a more detailed layout of care settings. And again, as Tim noted earlier, the highest absolute growth will be in the inpatient setting. And what we even forecast small reductions in RN demand in school settings, and that's primarily secondary school settings, and our all other catchment category. But the bottom line is, in terms of percentage growth, we see a great deal of it happening in home health and residential and nursing home care settings, which we've discussed. Next slide. Okay, and then you've seen this slide also. The projected growth in about 15 health occupations by profession. Again, look to the center of the slide, you'll see quite a lot of projected growth in direct care services and to some extent diagnostic services, certainly much higher than projected population growth. Next slide. Thanks. So we mentioned that we modeled a number of different scenarios to compare with the status quo to try to get a better understanding of what healthcare delivery patterns would look like under different emerging care models. And in this case, we looked at team-based care, care coordination, disease management, and integrated care, and basically parsed out the implications of changes in service volume and the implications of that on shifts and changes in health workforce demand. So Will is going to present the first few of these scenarios, and I'll step in and present several as well. Next slide, thanks.
Right, so Terry just mentioned kind of the 4 core components of our high-performing Vermont healthcare system, which are expanded access and team-based care. And so the modeling scenario we did under this sort of component is expanded access to mental health and substance abuse services by integrating primary care and mental health services together. Our care transitions component modeling scenario would be reducing ED visits by focusing on redirecting care for at-risk populations or for people who may be using the emergency room potentially, inappropriately, redirecting those people to primary care settings. Under clinical improvement, we've got our cardiovascular disease management initiative, and then we've got our integrated care delivery scenario. Okay, so everything that we'll present, all of these different scenarios will be presented relative to our status quo scenario. So that's what Terry kind of just presented to you guys, all those results for our status quo. And that's basically based on population change, growth and shrinkage, population aging, and just population change over time. Again, the healthcare use patterns for now are following national healthcare use patterns with in certain instances are informed by our analysis of the uniform hospital discharge data set and in the future the VCures database. And the healthcare use patterns remain the same over time. So those are our status quo modeling assumptions. And again, all of the scenarios that we present the results will be presented relative to the status quo. Okay, so our first scenario here is our expanded access and team-based care scenario, and that's the integration of primary care and mental health and substance abuse services. So obviously the purpose of this is, better screening for those people with mental health and substance abuse needs, better managing comorbid physical and mental health substance abuse needs, and so on. And so the target population for this scenario for our modeling efforts was the Vermont Medicaid or uninsured primary care patients with mild to moderate depressive anxiety disorders or substance abuse who are not receiving specialty mental health and substance abuse services. So we've got a modeling assumption here that presumably, I think that's 15% of the Medicaid or uninsured primary care patients are not receiving specialty mental health and substance abuse services that need to be. So that's kind of our population that we're starting with. We further assume that 80% of these people will visit a primary care provider during the year. And I should mention that these assumptions are coming from, when we go through the scenario modeling assumptions, in general, they're typically coming from published literature, or maybe we use a previous initiative to kind of extrapolate their results into some of these scenarios. I think we cite the sources more specifically in the report, and we don't necessarily have the sources in the slides here. But yeah, so 15% of the target population has unmet mental health and substance abuse needs, and 80% of those with unmet mental health and substance abuse needs will end up visiting a primary care provider during the year. So if we go to the next slide, even further, we would assume that 50% of the patients with unmet mental health and substance abuse needs would be successfully diagnosed. So we've got first our target population. We've got our target population, and then 80% of these people will visit the primary care provider. But then here we're saying 50% of these people under the status quo would be successfully diagnosed and referred to a primary care provider. But under this initiative, that 50% would get bumped up to 80% due to better training of the physicians, or the mental health and substance abuse staff that will then be integrated with the primary care physician. Okay, so the next step is then to estimate the proportion of diagnosed and of those people who were diagnosed and referred, who then actually go on to complete the referral. So under the status quo, 25% of these people would complete the referral, 50% wouldn't. So we're starting with our target population. 80% of these people visit a primary care provider during the year. 50% of these people under the status quo would be correctly diagnosed and referred. Under this initiative, the 50% gets bumped up to 80%. The 80% then of people getting diagnosed and referred would then go on to complete the referral under the initiative, whereas under the status quo scenario, only 25% of these people would have gone on to complete the referral. So it's basically the population's getting subset a number of times. It's a little bit hard to follow, but maybe we can go to the table on the next slide. And okay, so here we see kind of actually, before we get into this, let me just explain how to read this table. So in the top maybe 7 rows, we've got the population being modeled. And we kind of go through this subsetting process as we go down. But basically, the last line under this population model is showing the change in the population receiving mental health and substance abuse counseling under this initiative. So that's kind of the difference between our status quo projection and our initiative projection. So we're saying in 2030, about 4,600 more people would be screened if we were to implement this initiative. So as we go down the table, we've got the healthcare use impact of the integration. So we see, more about 13,000 more interactions with a mental health or substance abuse care manager. About 1,500 more primary care visits, and then some small reductions in ED visits and inpatient days due to this scenario. Okay, so now going down to the workforce implications of the scenario, we see that we would need about 31 extra licensed clinical social workers compared to the baseline, and I'm reading the 31 out of the 2030 column. So by 2030, we would need about 31 extra social workers, 3 psychiatrists or psych nurses, some admin support, and the effects of this scenario on the ED and inpatient settings are fairly small, but there are some reductions in some of the staff there. Go ahead.
I have a couple of questions. In that last piece that you were just mentioning, you said by 2030 we would need 31 additional licenses. I mean, the number's going down from 2015 to 2030.
Yeah, that's a good question. So the 2015 numbers are, I should have brought this up at the beginning when we got to this slide, but so the 2015 numbers are just assuming that this initiative was already phased in. I mean, it's not realistic, but it's just we didn't apply any phase-in assumptions But so the trend over time isn't really what to be looking for here. It's just more like, so if the numbers here are positive, it means relative to the status quo, we would need more providers in this initiative, or if we were to implement this initiative, or if the number was negative, we would need fewer providers if we were to implement this initiative. But so the 2015 numbers in this table would be as if the initiative were already implemented.
But does that add on each year? Is it?
No, it doesn't. Yeah, it doesn't add on each year. So
yeah, and Will, I would just also add that the demographics of the people that would use mental health services is very different from, say, the demographics of the patients who would use cardiology services or other types of medical services, in the sense that this tends to be children and maybe middle-aged adults. And so that's why sometimes you can see, for example, the demand from this initiative going down slightly over time as the demographics change. The demographics who would use the service, yeah.
Just to align slide 36 at the bottom of slide 35, it says the staffing assumptions, it includes addiction, 25% addiction counselors, 15% psychologists, and those are omitted from the slide 36. And just knowing that so much of mental health and substance abuse services are delivered by licensed mental health counselors, psychologists at the master's and doctoral level, and addictions counselors, it's a huge workforce. Not to mention the percentage of those that work in independent practice and how this is being linked up with these integrated models that are being put forth here. The services being provided by clinical social worker or team managers who are helping triage patients that have these issues and trying to give some form of treatment within those settings versus some emphasis in demand modeling, linking patients who are going to be screened and diagnosed and treated out into the community of providers that are providing services there, and that seems to be omitted from every integrated care model I've ever looked at. So.
Yeah, that's actually a good point, and the we've licensed this as 31 more clinical social workers, but really that could be a mix of licensed professionals.
Okay.
Anything else? No?
We did have one more question on the webinar, and that is, are the FTE implications cumulative? And that was Charlie.
No.
Okay, thank you.
I have just a couple of questions, comments. So on slide 26, where it breaks it out by hospital service area, how did you account for the need for a good chunk of the Vermont population is seen by physicians across the border, particularly in New Hampshire, Dartmouth, Hitchcock, in that area?
Yeah, and we know that, and that's an adjustment. That's an adjustment we're going to make when we get the VHCURES data, because we know we'll be able to identify the migration factors out of that data. Yeah.
Okay, and then I'm not sure if it applies to the modeling piece for you, but just something to put on the table for us in the system as a whole relative to avoidable reduction of avoidable ED visits. And so, I mean, some of the things that we're looking at, like a 50% growth in the senior population, things like falls prevention, increased access to senior nutrition. So you're thinking beyond the typical scope of, typical healthcare to the broader supports and interventions and initiatives that the state's working on. So how might that be considered in terms of this type of modeling? I don't know. It's just something I thought about when we were going to do that.
How would it be incorporated into a care transition type of model?
Right. I mean, there are initiatives underway, and it can much more work needs to be done, and advocacy for increased funding from the Older Americans Act to kind of support the broader continuum of care overall. But, the things that are in the works and how that might be, because that's a huge driver of ED costs for elders. So.
What we were focused on was generally avoidable ED presentations as determined by a group of primary care and designed for Vermont by the Lewin Group.
Falls are one of the Vermont is very good in many senior
Right.
health metrics. We're terrible at falls with our old rickety houses and so many hazards. So tracking that data has been difficult. But anyway.
I think I want to expand on that question in a way. Because I guess that's something that's just sort of like playing in my head, which is how does the model account for evolution and the way that care is delivered in ways that are not necessarily explicitly tested here? And like an example might be psychologists prescribing psychotropic medication, the efforts to prevent falls that might be statewide, surgical interventions like TAVR procedures that don't require cardiac bypass for the health.
Those can be modeled as scenarios, so long as we have reasonable data and reasonable modeling assumptions.
But like emerging technologies, kind of things, same-day knee replacements, those kinds of things. And like, does each one of those one-offs, or are there sort of trends that you can see nationally that might impact the way that you model?
In some cases, yes. In some cases, no. I think, as I mentioned earlier, in a lot of cases, outcomes are preliminary, premature, not fleshed out yet. And in too many cases, the outcomes are focused on answering other questions, like what are the financial ramifications? What are the impacts on quality of care? They haven't gotten around to workforce yet, unfortunately.
But I think the question you're not asking is, hey, after we do this initial scope of work, is it possible to do updates to this based on the evidence that comes through with some of this emerging work? And I would say that that is a decision for 2017 to determine what exactly would happen, and really needs to involve, in particular, the new Secretary of Administration's appointee to this work group. So I can, we'll document it and, put it forward as a question, but I think the potential future use is a valid one to have.
Thanks. Should we move on? Okay. What slide are we up to? This one. Thank you.
Okay, right. So our second modeling scenario gets us to the enhanced care coordination. And so this scenario is about reducing avoidable emergency department use. So obviously the goal, would be identify the patients who could be better served by a primary care provider than going to the ED for whatever they're coming in with. So we might do that by linking patients without a primary source of care to a primary care provider, referring patients to health homes, if that's appropriate, and just educating patients in general on, appropriate use of the emergency department. So the population that we would be targeting in this scenario would be just patients that are coming into the emergency room with conditions that have been determined to be avoidable or potentially avoidable based on the algorithm that Terry was mentioning that was developed by the Lewin Group. So the components of this type of program would include, hospital connectivity to community-based primary care providers or home health providers, care management support, or extended patient care hours.
Actually, before you jump on, I said because this is built off of something we actually are doing in Vermont and are just finishing our third year of measuring this could be one of those earlier interventions that we'll actually have information about that we can look at compared to some other stuff. Thank you.
Thanks.
Okay, so how do we go about reducing these ED visits that we think are avoidable, kind of in the modeling process? So we went to the Vermont Uniform Hospital Discharge Data Set and we first classified all ED visits kind of by ICD-9 code into a broad diagnosis category. So these are the categories that we see on the table here. And then what we did was, using the Lewin group's classifications of whether or not a particular diagnosis was avoidable or potentially avoidable, we calculate the percentage of Vermont ED visits within these broad categories that the algorithm would consider to be avoidable. So then, the third step is then just scaling down our modeled number of visits by the percentage that we think will be potentially preventable, and then kind of get our scaled down new number of ED visits, and we look at the workforce implications of that. So on the next slide, so basically what we did, go ahead.
If I can just add, we're not specifying exactly how this would be achieved, but rather we're referring to the literature that people think this is achievable, using different types of interventions. But they think these are numbers that could be achieved.
Right. And so this first assumption here, we're assuming that 25% of these avoidable or potentially avoidable visits will just be avoided. And so we're looking at the workforce implication of specifically reducing 25% of the avoidable ED use. And if you guys are interested in looking at a different percentage, we can update that input there. But yeah, I mean, the other assumption is that we would then shift these visits to primary care physician offices. So when we look at the table again, we see positive numbers in the ambulatory care section, which indicates that under this scenario, if it were to be implemented, we would probably need more staff in ambulatory care settings relative to the status quo scenario. So we see, in 2030, we would need 38 extra primary care physicians compared to the status quo, 15 extra NPs, 10 extra PAs, 18 extra RNs or LPNs. And then in the ED, the major stories are, 8 fewer emergency physicians required under this scenario, and about 50 fewer RNs required. So basically, that's just shifting from the ED to ambulatory care settings.
Can I ask a quick question here? Can you sum these? Because it looks like you're basically saying if you move the visits from ED to ambulatory, you're going to need more workers. So there's 70, the delta is 70 in the ambulatory, and the delta is negative 60 in the other one. So
70, just across the different professions.
Mm-hmm.
Yeah. Or you could sum it profession by profession, and maybe you assume that some of these ED RNs go, some of these can be absorbed with the excess, ambulatory RNs that would be needed, So
in an existing capacity, is what you're saying?
Well, there might be some retraining required.
Right. Okay. Because for some reason I thought that we were looking at like a reduction in avoidable ED would result in overall savings in terms of person hours. But this doesn't appear to be
so the assumption is that the need would then shift into the ambulatory care setting. So these patients are still, present, but they're just using ambulatory care services rather than that.
They're being seen in a more appropriate and, one would hope, less costly setting. When you shift out of the high-cost emergency departments to much lower-cost ambulatory care, one of the goals, of course, is to achieve cost savings.
Yeah, I guess it's interesting because I hadn't considered. Well, I had always assumed cost savings came from compensation costs related to occupation. But now that's making me wonder how, because I'm outside the industry, how ED is so expensive, isn't it just related to the fact of the structure?
Yeah.
If this thing is going to take more person hours to deliver the care that is done, then there must be savings outside of direct compensation to individuals. It's got to be in the form of technology.
Well, there's a lot of required standby capacity in EDs that you don't have in ambulatory care settings,
Right.
and that standby capacity is very expensive. So just this type of shift can result in significant cost savings. And naturally, from the policymaker point of view, that's always a good thing.
And this is a place where I thought maybe emerging roles might be reflected, like a community health worker that was interfacing with a vulnerable population at a lower cost.
We actually plan to add a scenario like that, utilizing health navigators as the community worker, and modeling out what the implications of that can be.
Okay.
We just didn't get to it in time.
Okay.
Anything else?
Good. Next. Is this mine or yours? I forget.
I'll take it.
Okay.
Okay, so our third kind of area is chronic disease management. So the modeling scenario here is the cardiovascular disease management scenario. And basically, we're assuming, we can get better medication adherence, we can get blood pressure and cholesterol under control by sort of better educating the patients on maybe self-management or having, certain members of the workforce kind of help out with that, patient education, medication adherence type strategies. So the target population here is all adult patients with cardiovascular conditions, and this is in the state of Vermont. And then we assume, just for modeling purposes, that we have 50% participation from this target population. And again, we can change this assumption pretty easily if you guys want. So our other modeling assumptions are that improved primary care management, or improved disease management, I guess I should say, would decrease CVD-related emergency visits by about 20%, decrease hospital inpatient days by 39%. But then, maybe it would increase visits to primary care providers by 1 visit annually, and increase visits to cardiologists by half a visit annually, or 1 visit every 2 years. And then we would assume that health coaches would be used in a ratio of 1 to 2,000 patients. Okay, so let's just go to the next slide, because this has information that's in the table. Okay, so at the top here, we've got in 2030, we see that there would be about 92,000 patients that would be participating in this type of information. In this type of intervention in the state of Vermont. And we see, as expected, the reductions in emergency visits and inpatient days compared with the status quo. But then we also see sort of large increases in the numbers of primary care visits and cardiology visits. So the workforce FTE implications reflect, the increases and decreases in visits by setting. So we would need about 42 extra primary care providers. We would need, 13 extra cardiologists, 31 extra registered nurses compared to the status quo in ambulatory settings. Pretty small workforce implications for the ED, and maybe we need 1 less hospitalist in the inpatient, 12 fewer inpatient registered nurses, but not huge workforce impacts in the emergency and inpatient settings.
Any questions?
there was a question that was raised. It was actually backing up a couple of slides, and it was asking about the if dental pain was reflected on, what was those slides? Slide 38. Slide 38. Sorry to back up a little bit. If you're avoiding ED, you'd like to use disease capture, avoiding it if there is additional, I guess, dental access. That means that folks aren't showing up in the ED due to dental pain.
Off the top of my head, I don't know the answer to that. I could look into it.
Good job, Stephanie, for stuffing them. We'll get back to you on that one.
We have to see if it's in our algorithm or not.
Yeah, it's basically a big list of ICD-9 codes that could.
Yeah.
You don't have it memorized?
Yeah. I'm working on it.
We'll save that for the final meeting.
All right, so stay tuned. We'll get back on that one. Thank you.
Although, dental pain is a bigger growing issue. It's a growing issue as people don't have access to routine dental care because of the difference between need and demand, as Tim mentioned.
Yep.
Okay. So, okay, so pass this on to me. Our integrated care delivery scenario. And what we were looking at as we examined different integrated care delivery scenarios or assumptions and models, we said, what would the goals of this be? And a lot of the goals of integrated care delivery are to improve coordination of care, and through that to improve quality of care, and to shift care from higher to lower cost settings and health workforce, and to improve preventive care as well. A large focus of integrated care models is starting with population preventive care. So we asked ourselves, we said, well, what would happen if 100% of the Vermont population were enrolled in an integrated care program based on what we know about such programs? Next slide. Thank you. Well, the interesting thing that we found was that under this scenario, compared to the status quo, in total, we didn't see much of a change in total health workforce demand. But what we did see was a shift out of medical specialties and the category other specialties, which includes just about everything that's not surgical or internal medicine or primary care related. And that shift moved to increased demand for primary care physicians. And interestingly, and this is something we want to look into in a little more depth, we saw increased demand for surgical specialties.
Hey, Terry.
So,
Terry,
Tim?
I think much of the increased demand for surgical was obstetrics and gynecology.
Okay. That's going to appear on the next scenario as well in a different context. So it's interesting that what we see in integrated care is not necessarily large absolute changes in demand, but shifts away from medical and other specialties such as OBGYN and towards primary care and to some extent surgical specialties, which not a bad thing. It's probably the direction we want to go. Next slide. Well, this is not exactly comparable to the scenarios the other four scenarios that we just described to you, in that it's not a component of a top-performing Vermont healthcare system, but it's an interesting scenario from a policy point of view and from a point of view of how different populations have different healthcare use patterns. So what we asked ourselves here was, what would be the implications on physician demand if the Medicaid population had the same healthcare use patterns as those individuals covered by private insurance? What would the implications of that be for physician demand? Next slide. Thanks. And so what it suggests is that full-time equivalent demand would be lower for all professions that were modeled. And by 2030, we would project that demand for RNs would shrink by over 460, by about 470 FTEs. And among physicians, demand would shrink by about 90 full-time equivalents with those, and in addition, the physician specialties particularly impacted would be psychiatry and OBGYN. This is if the Medicaid population adopted care use patterns consistent with individuals covered by private insurance. We would see a shrinking in demand, particularly among, as I mentioned, psychiatry, OBGYN, primary care, and registered nurses. So we thought this was sort of an interesting modeling exercise to look at in terms of population health and different care use patterns. And this is using Vermont data. So it's interesting.
I would call it interesting but not surprising, given
Right.
the burden of disease, the two populations.
Right. Well, we've tried to
do with that.
That's right. What we tried to do is translate that into workforce implications, or at least take a first cut at that. There's a lot of subcuts you could do on this. You could look at urban-rural. You could look at Medicaid, urban versus commercial rural. I mean, there's so many subcuts you could do, but which are the ones that are most interest to the group. So next slide. So those are some of the preliminary scenarios that we've run so far. We still have some on our plate to run. Among those are the community-based navigators and the implications of that, and there's several other scenarios as well. And we hope to be able to do that once we get the VHCURES database. So one of our next steps is to analyze that database to refine the outpatient and physician office and long-term care components of the data. And as I mentioned, there's going to be a number of other scenarios that we plan on developing with feedback from you. And then what we want to do is put it into a report and have you folks review draft and final reports and get your feedback and move on from there.
So I think we will open it up with that 20 minutes. A few more questions that folks may have. I don't think there are any that have come through on the webinar, but are there any other questions in the room that folks have?
Can we just do a refresher on the timing on the next step?
Yes, so the timing of next steps is we have extended the contract with IHS Markit so that they can actually use the VHCURES data, which was unfortunately delayed in getting to them. So we have, I think we're hoping to have everything done by the end of March.
Right. That's
and so the next step really is getting the VHCURES data, doing that analysis, and that will take some actual time. So I wouldn't expect another set of information until January, later January, February. I'm visualizing the table of deliverables. I think it's late January, early February. We do have a draft report in hand that IHS Markit gave us, and include the information you've seen to date, but obviously it will be updated.
And much more detailed.
And much more detailed. So I think to the extent that when that gets ready, we would also distribute that out to you all. Let's see, if you have additional data that you can toss our way, send it in the next 3 to 4 weeks. I think that would be super helpful. If folks have additional questions, comments, issues, concerns, anything, if you could let us know by the end of December, and not because I'm trying to give an arbitrary deadline by the end of December, but I think by that point, this webinar will have faded in our collective memory. And we'll remember all of the things that we thought of. So giving a slightly shorter deadline to make sure that it's kind of fresh in folks' mind. And we'll send that up a little ding reminder to you all by email.
And we send that to Amy.
Your friend Amy.
Okay.
She collects all the information for you guys.
And she throws it at us.
I wonder if there are resources to look at evolving healthcare worker who might use certain types of things, with the coaches or those kinds of things. But are there national resources at GDNC or whatever that look at trends in scope of practice that might inform your modeling in a more general way?
Well, I think we actually keep an eye on those developments, and we update our model structurally every year to reflect updated data input. Yeah. It might take a while to get fully incorporated, but.
So one of the things we actually talked specifically with these folks was about the new dental therapy law that passed in Vermont being so new. And I think so there's, because of experience in other places, there's a little bit of information about that, but similar to the naturopath question, which is you actually need data.
Yeah, darn it.
Darn it, you need that data. But, I would say that if there's other things like that, questions or things like that crop up, I think there's just to keep on the horizon of, hey, wouldn't it be great if we could get ABC? So I think that would also be helpful in addition to the questions and other comments folks have.
And what about the age of the workforce and the numbers in the educational pipeline? Does that fit in here at all?
That's a supply analysis.
So that doesn't, so that has to happen. That was one of the recommendations for future research.
I'm just going to want to go to see if there's any more questions that came through in the webinar. This is for dynamics where we can't listen to people. But are there any other questions that came through? No. Nope. Okay. Any other questions in the room? Oh, yes. They're breaking. So the comments from Paul Bankston that he says that he thinks we shouldn't worry about being overly precise about numbers. The patterns are pretty obvious. So he's interested in preliminary thinking about how one would go about developing an action plan to make our way through this very complex path to success. And that would include how the supply is developed. I don't think we have much time for more research. So I'll send that one over to Mary Val as gives us a previous comment of a similar nature.
I think Paul is reflecting, the frustration of being an administrator in the Northeast Kingdom and being very, very concerned about supply and demand over the coming years. Yeah. And, I don't know what else to say other than what we're trying to innovate and just try to have an eye on the future.
Thank you.
Does anyone else have anything to say?
Well, I would just say that the mismatch is sort of an interesting question, and then I would go back to my first question about the dental care. I don't think Chittenden County needs another dentist. We might need one, but maybe one. Whereas I would guess that in rural areas, that's like a burning, so that there are, this is big picture maybe for Vermont mostly and some of New Hampshire, but there's also sort of regional differences that are really going to be important in terms of workforce recruiting and all kinds of retention. I can't imagine how your model is really going to address that, but there are major regional differences even in the states.
Yeah, I think part of the benefit of the VCures data, frankly, is it gets at some of that regionalization, and the fact that there's a bunch of people who go over the border, either to New York, Massachusetts, or New Hampshire. So, I'd say it's not the most precise tool, but I think that helps to get at some of that issue. But there's fundamental challenges with maldistribution, I think, everywhere. But we have them here too. If there are no more questions, I want to thank our IHS Market team, so Terry, Tim, and Will. Thank you guys so much.
Thank you. We'll be back.
Yes, stay tuned for folks in the room. They will be coming back, and we'll be sending some other communications out electronically. Back to you, Maribel.
Great. Well, did we ever get a quorum? So you had a quorum, but a couple of people have departed.
Yeah.
So you no longer have a quorum.
Mhm.
Sorry to say.
Okay, well, we'll have to table the minutes for our upcoming meeting, which we are hoping is in February to be announced. The location, time, Wednesdays 3 to 5, tend to speak best for people. So, okay, without further ado, thank you all, and have a safe trip home.
Thank you. Thanks.